I'm Dr. Michael Faki. I've been in the field of IVF for at least 30 years. I've been doing all types of procedures, including embryo transfers all this duration. Done thousands and thousands of embryo transfers, and would love to talk about the process and the catheters used for this procedure. Definitely, we have to have ultrasound guidance. It's a must. Because you need to know exactly where the drop is going. You need to know exactly if there's any backflow, and then you have to trace the bubbles. So it is a requirement to have ultrasound guidance. You know exactly where the drop is going, and you know exactly where to deposit the embryo. It's a very important innovation, and I think it has increased the success rate in embryo transfers tremendously because you know exactly where the embryo is deposited. Many problems can happen with embryo transfer, and if you don't have the right equipment or right instruments, then your success rate will not go up. So to have the best outcome, you need to do ultrasound. You need to have the bubbles that you can see with the ultrasound. You have to see the tip of the catheter. If you don't see the tip of the catheter, then your procedure will fail most of the time. So you have to have a technology that shows you the tip of the catheter. You need to know exactly where the embryo is going. You need to know exactly if you're hitting any wall of the fundus or if the embryo might come back. You can see it with the scan machine, and then you can act accordingly. So sonography is very important. The type of catheter is really important. And if you know how to use both, then your success rate with embryo transfer will be very high. The difference between one stage and two stage, the one stage is you just get the catheter loaded and you insert it into the uterus. This one is okay with professional physicians who've been doing this for many, many years. If you're fresh out of fellowship or during the fellowship, it's better to use the two-stage transfer because you're sure the catheter is inside the cavity and you will not struggle getting it inside, because the more you manipulate, the worse the outcome. Any type of bleeding can affect the outcome. Any type of hypercontractility of the uterus will affect the outcome. So for fresh graduates, it's best to use the two steps. For the professionals, one step is enough. So this is the ProSure catheter. You have the catheter with the stylet. You can remove this and you can put it back. And this is the catheter that you will load the embryos to, all right? So the one step is where you insert this catheter into the outer sheet, and then you can really manipulate this the way that you see it on the ultrasound. This is why ultrasound is important, because you can see if the uterus is anteverted, retroverted, or straight, and you can manipulate the catheter whichever way you want to, all right? So if the uterus is anteverted and you want to have a little curve, you can do this, and it will guide you inside that way. And then you can actually, like it's very malleable, you can do it whichever way. See like how the memory is? So that's very important, all right? If it is a straight cavity, then you can straighten it out and then you can go this way. If it's retroverted, you can always turn it around and go this way. So this is a model of a uterus, vagina, cervix, and then the cavity. Typically, I deposit the embryo right in the middle. I don't take the catheter all the way back, because if you go all the way back, you can hit the wall of the fundus and then it will come back. So the inner catheter should be right at this point in the middle of the cavity, and then you deposit right there. It will go, sometimes it will flow all the way up to the fundus, but that's the way to do it. If you go inside and breach the wall, then this will hit, I don't know if you can see it there, but it can hit the wall of the fundus, and then the embryo will either be trapped in the catheter, and this can cause a collapse of the embryo, or if it comes out, it will flow all the way back to the cervix. So this is why it's important to deposit the embryo in the middle of the uterus rather than at the top. That's one. And then this one will take the shape of the uterus, whichever way it is. The mock transfer is very rarely needed. especially if you do a good ultrasound on the patient when she's coming for stimulation. So you can look at the cervical canal and you can look at the cavity. It will show that it's straight and there's no need for a mock transfer. Sometimes if you have a niche or you have any previous surgeries on the uterus, like multiple C-sections and so on, you might want to use it, but most of the time you don't really need to do it. If there's any cervical stenosis and if there's any previous difficult transfer, then you might want to do a mock transfer. I've been using the 20 centimeter for like the past 15 years, very happy with the results. We very rarely need a longer or shorter catheter. There were other companies that made other catheters, but as soon as I tried the Wallace many years ago, from my days in Michigan, which was like about 15, 20 years ago, we started using the Wallace catheter. And it's always been the best catheter to use. And then with time, they developed new technology and new innovations in the catheter use that has made our life easier as physicians. So this is a good catheter. I definitely recommend it, not because I like Cooper, but because it's a good catheter.